Good evening, everyone. Welcome to the Together Facing Sarcoma event tonight from Fox Chase Cancer Center. I would like to thank our patients, caregivers, advocates, and guests for joining us this evening. I'm Dr. Jeffrey Pharma. I'm Chief of the Division of Surgery and part of our wonderful sarcoma team here at Fox Chase. Tonight, my colleagues and I will share the latest research and treatment developments for sarcoma. Typically, we can gather in person for these events, and we wish that we could all do this together at the center like we have in the past, but we hope that you find what we have planned to be both inspiring and informative. Throughout the program, please feel free to leave questions in the chat feature on Facebook, and we will get back to you later in the evening with answers to those questions or even after the event. At our Together Facing events here at Fox Chase, we traditionally begin with honoring those that we have lost to cancer. Please join me for a moment of silence. Thank you. I'd also like to take a moment to thank our exhibitors for this evening. It's because of their generous support that we can offer this free program to you tonight. A special thanks goes out to our gold exhibitors, Caris, Genentech, and Tempus, and our silver exhibitors, Deciphera and Epizyme. Also, thank you to the Sarcoma Foundation of America. We've had an amazing relationship with them over the years and for their ongoing partnership and support in the community and to our sarcoma program at Fox Chase. And with that, I'd like to introduce our panel of experts tonight. Each of our panelists will take a few minutes to introduce themselves, and I'm proud that these are my colleagues that we get to work and share patients with and work together on a daily basis. And with that, I'm going to start with Dr. Stephanie Greco. She is one of my surgical partners. She's an assistant professor in the Department of Surgical Oncology at Fox Chase, and will give us an overview of how we identify and think about surgery in the management of sarcomas. Stephanie?
Thanks, Dr. Pharma. So I'm very happy to be here and be part of this wonderful team here at Fox Chase. So I think one of the things that I would like to highlight is really the role of surgery in combination with our multidisciplinary care. So I think that one thing is very important is when you're diagnosed with a very rare disease such as sarcoma, to come to a cancer center that has a sarcoma team, because often surgery is not necessarily the first treatment method for many of these diseases. And I think it's important to be seen by a surgeon early. And what we do is we work very, very closely with our medical oncologists like Dr. Van Meeren, our radiation oncologist, Dr. Howell, who we'll hear from later. And we really plan an individualized treatment plan of how to time and best use these therapies in combination. And I think that is really, really important. So, sarcoma can obviously occur in many different locations in the body. Primarily, we treat sarcomas within the abdomen, but also on the extremities and as well. And, the surgeries vary widely in terms of the techniques that are used. Here at Fox Chase, depending on the location, we do offer, both open and minimally invasive techniques to remove these tumors, depending again on the location. But we very carefully plan these surgeries, as I said, in combination with other treatments and also other technical aspects of the procedure. So, the majority of these cases are presented at our tumor board, and we review together, our entire team, about the best operative strategies. We do have options to do novel techniques within surgery. We work closely with Dr. Howell, who may be talking to you about later about using radiation sheets that can be placed at the time of surgery to help prevent recurrence in the surgical site. And that's something that's very novel and unique and is not used widely at other centers. So I think, what I'd also like to highlight is just, the other surgeons on our team as well. We work very closely with our plastic surgeons who are excellent, again, depending on the location, to really, help us give you the best, surgical outcome as possible. We have our orthopedic oncologists also available on our team, depending on the location of the sarcoma on the extremities. And we all work very, very closely together. And as you'll hear from later as well, we also work with our physical therapists who are great experts in helping us manage patients both pre and post surgery, so both before and after. And I think that's very important. Surgery is involved in the care of majority of patients with sarcoma, but the timing and the planning of the surgery is really critical to achieving the best outcome. And so that's something that has to be very carefully reviewed and considered. In addition, as many of you know, sarcoma covers a wide range of different types of tumors. And so the first thing that we'll do when we see a patient for a new consultation for sarcoma is have our pathologist very carefully kind of review the slides and the diagnosis. That also very much determines, often the type of treatment that we will use and sometimes the surgery as well. So I think that is all kind of very critical to how we treat patients with these tumors. So those are the things that I wanted to kind of focus on. But we, again, offer kind of a wide range of different surgical techniques for these tumors. And we work very closely, with our other colleagues here.
Great. Thank you, Dr. Greco. All excellent points. And I think you'll see throughout a lot of these events, and specifically for our sarcoma event, that this is a team sport. We're only as strong as, our team, and that's really provides the best care that we have. Next, Dr. Krisha Howe will talk about novel approaches to radiation oncologists. We're exceedingly lucky to have Dr. Howe as part of our team. She's an expert radiation oncologist for sarcoma, which is really a very, not many institutions around the country or world have the expertise and knowledge that Dr. Howe has. So thank you, Dr. Howe, if you can enlighten us and kind of how you think about sarcoma from a radiation oncology standpoint.
So thank you, Dr. Farman. Thank you, Dr. Greco, for the introductions. So yes, I'm radiation oncologist here at Fox Chase, and I practice at the Fox Chase Center, but I'm also very lucky in that I work very closely with other radiation oncologists at other satellite centers that may be closer for certain patients. And what we do here at Fox Chase is we meet with the patient, we come together as a team for nearly every new patient, and we make a plan that's individualized to that patient, their tumor, and also some of their limitations or social factors. And so I do work with some team members at other satellite institutions or satellite centers, and we can help navigate patients that are appropriate to those radiation oncologists. We also, I want to say, offer telehealth visits, both in radiation oncology and in other departments or divisions. And those might be good for patients who have issues with coming to see us or might be seeking a second opinion. And so a lot of times we can be there to review a case and kind of help them come to a final decision. So within the realm of radiation oncology, we do make decisions in partnership with our surgeons, our medical oncologists, geneticists, wound care professionals, and other members of our team, which I think is paramount to your outcome. So sarcoma is a rare cancer, and so it's important to go and seek out a center that does routinely see sarcoma. And here at Fox Chase, we do see a very large amount of sarcomas because it is what we specialize in. As far as radiation oncology goes, we have a lot to offer the patients. We have what's considered external beam, or radiation that comes from the outside and travels inward. And we have a couple different modalities to deliver that radiation depending on the patient's type of sarcoma, depending on whether it's their first time receiving treatment or maybe their second or more. And we also have radiation that we can implant or deliver directly to the tumor that goes inside and then radiates from the inside outward. And that is what's considered brachytherapy. Not a lot of institutions can offer this, and we have more than one way in which we can offer brachytherapy here at Fox Chase. Sometimes we partner with the surgeon and we will go with them to the operating room if a patient is a candidate for brachytherapy. And we work closely with the surgeon. We identify the area of concern and we can directly lay the radiation onto that area of concern at the same time as a surgical resection. We also have clinical trials or novel treatments that we work with both the NRG, which is a national protocol or research committee to develop new novel treatments. And we also work with companies that have novel treatments so that we can deliver those to our patients as they become available. We also have started a research protocol here, which is unique to Fox Chase. It's a microtron therapy. So it's delivered by a specific machine that delivers a lower dose of radiation at the same time as giving a photodynamic therapy so that the radiation ignites or initiates this treatment, which can then target the cancer both locally and regionally within the delivery field. And we see our patients while they're under treatment every week to ensure that they are making it through therapy with minimal toxicity. And we continue following them afterwards to minimize any potential toxicity from treatment. Thank you.
Great, thanks, Dr. Howe. Next is Anjali Albanese. She is our amazing sarcoma social worker. And I think that as a surgeon or, I think sometimes we get so involved in the treatment plan that sometimes we forget about the emotional kind of aspects of cancer sometimes. And I think all of us at times do this. And we all are, at least I personally, really try to incorporate that into my decision-making and offer we have all of these other things from social work to psychologists to psychiatrists that can provide emotional support for patients. A lot of our patients are young, but independent of age. This is a lot, having a sarcoma is a life-changing event, and we recognize that. And Anjali is always there to help both our patients out and I think us out as well with helping our patients in difficult situations. So thanks, Anjali.
Thank you, Dr. Farma. So my name's Anjali Albanese, and I'm one of the social workers here at Fox Chase. And I am truly lucky to be part of such an amazing team. Working with the sarcoma specialist is a wonderful opportunity. I thought it might be helpful for me to describe sort of how social work fits into the team approach to care. And one of the things I really like to point out is that the social workers are all here to help patients cope with the distress that's oftentimes associated with being diagnosed with cancer. But we also recognize that it doesn't just impact the patients. Anyone who loves or cares for them is also being affected by the diagnosis. And then, as Dr. Farma said, when you consider other treatment options, how is this going to impact their life? And what aspects of their life are going to be affected by the diagnosis and the subsequent treatment? The one thing we try really hard to remember is that you and the people that love you had lives. You were a whole person prior to your diagnosis of cancer. So when you walk through those front doors and you come in to see us, we try really hard to sort of just recognize that you are a million different roles to a million different people. And we try really hard to be sensitive to that and to pay attention to, what are your needs beyond just the physical? Are you someone that might benefit from some emotional support? Are you financially really struggling because of the impact of the diagnosis? Are there resources that we can help put in place that can help you and the people that love you just feel more supported during this challenging time? Whatever it is that you think you may need, we try really hard to personalize our approach, not just from a physical impact, but also just from the emotional perspective of how best can we make you feel like a whole person and how best can we take care of you in that process.
Thank you, Anjali. Next is Dr. Margaret Von Meeren. She is the chief of the division of our division of sarcoma medical oncology. And Dr. Von Meeren has also chaired the NCCN panel, or National Comprehensive Cancer Network panel for sarcoma for years now, and really is inspirational and also, and helps to basically set guidelines internationally for treating all different types of sarcomas. So the impact of the NCCN and specifically in sarcoma is, kind of mind-blowing how we are creating, and Dr. Von Meeren is creating guidelines for the rest of the world on how to manage these tumors. And, these guidelines are evaluated every single year or twice a year and updated to make sure that we're staying on top and instituting changes and really trying to provide the best options for patients and care. So thanks, Meg, for everything that you do.
Thank you. And I want to say NCCN is also a multi-institute, a multidisciplinary group, just like our team. As a medical oncologist, I really focus on giving chemotherapy is the primary way of helping patients in their journey. Sometimes I'm giving chemotherapy to try and make a surgery easier and more successful. Oftentimes we describe this as neoadjuvant, before surgery. And sometimes there'll be radiation after the chemotherapy or with the chemotherapy. The other setting that I will give chemotherapy in is after surgery. Can I decrease the likelihood of a tumor coming back? And then lastly, it's in a variety of settings, patients whose tumors have recurred, and we're really looking to see, are there ways that we can help to control the disease and improve patients in terms of decreasing symptoms and any side effects that their disease is causing. I think one of the challenges for patients with sarcoma, particularly for practitioners who don't see this all the time, is that there are so many different types of sarcomas. And increasingly, our scientists and biologists are really defining them better. And we have increasing numbers of drug treatments that can target these specific sarcoma types. And actually, two of the sponsors this evening have developed drugs that are very specific for certain types of tumors. And that's exciting, but it also makes it a challenge to be able to understand all of those different medications and all the different diseases that you're trying to manage. One of the ways that we have at Fox Chase to help us is our pathology department, which really helps us in making sure that we have the correct diagnosis. And pathologists now not only depend on looking at slides under a microscope, but they also want to understand the genetic makeup of tumors, because oftentimes that helps with either the diagnosis or identifying specific medications that can help treat a patient. We also have radiologists who help us look at scans. Because of our center and what we do, we have specific radiologists who are experts at looking at what we call musculoskeletal imaging. So imaging that has to do, or scans that have to do with muscles and bones. Also, sarcomas can arise anywhere. And we've heard from the surgeons who focus on, the belly and extremities, but, we also I work with surgeons and we work with surgeons who address tumors in the lung or in the head and neck area. So having excellent imagers and diagnosticians who can help interpret all these different images. And then geneticists were mentioned earlier. And we are coming to understand that in sarcoma, like some other cancers that we think of more commonly, like breast cancer, there are some inherited disorders. And so understanding which types of patients benefit from being seen by our genetic counselors. And actually our geneticist comes and attends our tumor board and will pipe up and say, this person really should come to see me, so that we can talk about their potential risk for having something that they may have inherited, and all the implications that may have for their children, if they have children, their siblings, their parents, aunts and uncles. I'll stop there.
Thanks, Meg. And last but not least, Dr. Lori Rink. We all are at a place like Fox Chase because we want to provide the best level of care that we know. However, we also want to answer questions, and we want to improve on ways that we can treat all of these types of sarcomas. And I think with sarcomas, they're so different, and having a basic understanding of the biology is implicitly important in finding out new discoveries. And with that, I'll have Dr. Rink tell us about her lab.
Thank you, Dr. Farma. So yes, I do. I don't see patients. I do research in the laboratory, and I run a translational sarcoma research lab, which means that what we're doing is we're looking at patient tumor samples that are donated to Fox Chase. We're trying to understand the biology in terms of each of the different subtypes of sarcoma. We use sarcoma cell lines growing in dishes and flasks and incubators, and we grow tumors in mouse models. And our goal is to translate what we learned in the laboratory eventually into the clinic so that Meg and our sarcoma team can use some of this research to impact patient care. We primarily study in our lab GIST as well as LMS or leiomyosarcomas, but we've also studied liposarcomas and some other types of sarcomas. And one of the main focuses in our research is to study drug resistance. So we look at tumors and we try to determine what happens to the tumor when it stops responding to a given treatment. And then we try to identify new targets in these resistant tumors that we can test preclinically in those cell lines or in those mouse models to determine if new treatments or combinations of treatments may be effective. And my goal is always to gather this preclinical data so that I can pass it to Dr. Van Maren in order to initiate clinical trials. And I'm lucky to work with this team to get the clinical perspective, because sometimes us scientists can kind of get stuck looking at, cells and tissue culture or looking at specific proteins. And it's really useful to have my clinical colleagues kind of discuss what the clinical obstacles are. In fact, several members of this team sit in on our lab meetings and actively participate in the research that we're doing. And I've written grants, I think, with just about everybody on this meeting. So very, very grateful to be part of this team. Thanks.
Thanks, Dr. Rank. That's truly what we call translational science. It's really important that there's crosstalk back and forth so that, we're able to, if there's a finding that's seen in the lab, and then we can translate that to how we can best utilize that information to improve outcomes in patients. And so because of literally the proximity and the communication between our team, we're able to do that. With that, so we're going to open up to the audience for questions on Facebook. So please feel free you can place a question in the chat function. If we don't get to your question this evening, we will be following up after the event concludes and can answer some of these questions. One of the first questions, and this seems to come up very commonly because it's a very hot topic in cancer care in general, and we've seen great strides with this, but I'll probably ask Dr. Van Maren to kind of take this question. How soon will there be access to immunotherapy? And I guess, what is immunotherapy? And if there's novel approaches that you anticipate for sarcoma? And what part of the second part of that question is we're facing a recurrence of a tumor and hoping to hear about access to either clinical trials and availability of immunotherapy. So I think kind of a two-part question addressing immunotherapy for sarcoma, and then also the benefit and options for clinical trials.
So immunotherapy has been really exciting for many diseases, particularly melanoma, renal cell, bladder, and some others. And sarcoma, not quite so much. And why is that? There are certain types of characteristics of tumors, as well as we call the microenvironment, sort of all the cells in around tumors, that suggest immunotherapy might be helpful. And many sarcomas just don't have the things that we think of. Sometimes they're described as tumors that are hot, meaning they'll respond to immunotherapy, and those that are cold. And many sarcomas are cold. That doesn't mean that there's a lot of research going on now to try and figure out how to make a cold tumor hot. There are some examples, though, of immunotherapy that has provided some benefit to patients with specific types of sarcomas. There have been some studies looking at drugs like pembrolizumab or Keytruda or nivolumab, which have shown some activity in certain subtypes of sarcomas, in particular undifferentiated pleomorphic sarcoma, increasingly information about myxofibrosarcomas have been shown, and potentially some types of liposarcomas. There are also some tumors that have specific proteins on the cell surface that the immune system can recognize or target. And so some of these have been studied with vaccine type approaches or even CAR T cell studies. I think the greatest example of those would be tumors that have a certain protein called NY-ESO1 found on synovial sarcomas or myxoid liposarcomas. And so those are studies that are ongoing and have shown some benefit. So when they will become standard, I don't know, but we're all looking forward to that. There are clinical trials that do look at immunotherapy. Some have been specifically focused at sarcomas. Some are what we call phase 1 studies, which are really trying new approaches, either one drug or a combination of drugs, and oftentimes will be tested in sort of a multitude of tumor types. And oftentimes for sarcoma patients, that can sort of be the best way to try and gain access to immunotherapies. At this point, knowing what we know, I would probably suggest that for a clinical trial that's looking at immunotherapy in a sarcoma that doesn't have a specific target for the immunotherapy, that probably a combination approach is the best way to go. But I think we're making slow strides forward and looking forward to be able to show the successes that many other sarcoma types have been able to show with their studies.
Great, thank you. There's a question, and I guess this kind of got to be a combination answer from Dr. Howell and Dr. Greco. So, and then there's a second part of the question, but have you ever seen 100% response or necrosis of a tumor after neoadjuvant therapy, let's say, when you take it out? Do you ever see that? Dr. Howell, maybe?
Yes, sorry, trying to find my unmute button there. So with radiation, you don't often see 100% necrosis with radiation leading into surgery, but it doesn't discourage me because it's not really the role of radiation for this tumor. If you look at how radiation evolved for sarcoma, there's kind of two ways we group sarcomas, at least depending on location. One is retroperitoneal and the other is extremity, meaning arms and legs. And so when you look at radiation, how it kind of got a footing in sarcoma, it was kind of with the extremities. And way back when they used to do amputations, and that would take care of the tumor, right? And no one really wants amputation if they don't need it. So they started to look and see if radiation would help control the disease, meaning it wouldn't come back. And they could save someone's arm or they could save someone's leg. And they found that radiation was successful to do that. It prevented these cells on the periphery from reoccurring or regrowing. And so that's how radiation first started in the realm of sarcoma. And so even though you don't have 100% necrosis, when we standardly go into surgery for a curative primary sarcoma, it doesn't mean it's not a negative thing necessarily. If we do have 100% necrosis, that's great. But like I said, I've been doing this for a while now in specializing in sarcoma, and I don't routinely see it. But once again, it's not something that would concern me if I do not see it.
Yeah, I would say, I agree with Dr. Howell that, that would certainly be, I think, an unlikely event, but does not mean that the patient cannot have a good outcome. We do, that is something that is looked at carefully. So for any patient who goes to surgery who has had any type of neoadjuvant or therapy before surgery, whether it be chemotherapy or radiation, when that tumor is removed, the pathologist will look at that carefully to kind of quantify how much of that tissue that is removed is necrotic versus, live tumor. And so we do see, often very significant portions of tumor that have necrosis. Rarely would I say is it ever 100%, but we can also see necrosis from the other preoperative therapies like chemotherapy. And so that is something that we look at, but, whether or not it's 100% or not does not necessarily mean the patient cannot have a good outcome.
And so I would just add on to this, and then and Dr. Ramiran can answer kind of the second part of the question. But our goal is, so when we see 100% of the tumor is dead, so to speak, and necrosis kind of is a term that we use for the tumor being dead, ideally that's what we want. And so there are some situations where we can see that. And that's where we utilize kind of this neoadjuvant approach, or pre-treating the tumor with either the tools that we have, radiation or chemotherapy, or sometimes both, in hopes of achieving that. But the question, I guess, from this patient or family member was, well, if they had 100% necrosis, then how could they develop lung metastasis, or how could we see that? And can that happen? And so Meg, can you maybe expel on that?
So I think one of the things that we know about tumors or cancers or malignancies, one of the features of being a cancer cell is that you can travel. And sarcomas typically travel via the bloodstream. And they like to go to the lung. That's one of the most common places that we see metastasis. We very carefully have patients get scans, what we call staging studies, when they're going for their initial surgery, and looking to see, do we see anything else anywhere else? And most of the time, oftentimes we don't, but we can subsequently. The greatest risk for seeing disease recur after initial resection is within the first 2 years. And what that really tells us, if we see that rapid recurrence, is that probably the cells already had traveled to the lungs, and over the time after the surgery, when they were, we are observing you, getting scans to make sure nothing is growing back, the cells have grown. And that's one of the reasons why we sometimes talk about the role of adjuvant chemotherapy. Can we decrease that likelihood or delay the time to seeing a tumor recurrence? Our therapies in sarcoma are good, but not great. Many of the therapies come with toxicities. And so it's a risk balance discussion. What is the risk? What is the benefit? And then talking to a patient about their personal preference. What are their personal goals? What kind of risk are they willing to take in terms of side effects, their impact on their life, potentially loss of work, side effects, etc. In cases where it's clear cut, we make the recommendation, we definitely think you should do this. If it's less clear, we try and present the information, the pros and the cons. But we do see patients who've had a great local primary therapy with surgery, with radiation, sometimes chemotherapy, and then see recurrence. And that's unfortunately part of a cancer process.
The next question is a little specific, but then, and I'll get everyone involved, but Meg, this is somewhat for you. But the question was, have we seen patients or seen with epithelioid hemangioendothelioma of the peritoneum? That's one. And we've seen rare sarcomas in any location. I can kind of answer that. In terms of kind of treatment options for that, it would really be dependent on the imaging that we talked about and evaluating and kind of seeing where the tumor is. But one question was probably related to that same type of histology, but I think more broadly, are there any clinical trials using CAR T cells for sarcoma or EHE specifically, which I suspect probably not, but I don't know.
EHE is a disease that often presents with disease in multiple areas, lung, liver, bone. And it can vary in patients. Sometimes it can be very slow growing, what we call indolent, not causing any problems. And sometimes it can pick up its pace and grow and become problematic. We participated in the study just recently looking at a new inhibitor based on, again, the genetics of the tumor because of a specific biology in the tumor, and that will be presented at our annual meeting this year, hopefully, looking at the benefits of that. I am not aware of any CAR T cell studies that are being looked at for EHE at the present time. Doesn't mean that in the future it might not be, but there have been some very specific studies. There are some approaches that have been tried with some success for patients, particularly looking at tyrosine kinase inhibitors that target a receptor called VEGF receptor. So hopefully that's helpful.
Great. Dr. Rink, so how important, and I think you can comment a little bit, but how important are patients for what you do in one aspect? And maybe you can comment about how important to you. So, and just an overview for the audience about our biosample repository and what that is. And I think how important just overall that is to research and how long-standing that's been at Fox Chase.
Sure. So we have an excellent biosample repository at Fox Chase, a wonderful team of staff that works in the facility who consents all patients who are coming to the center to provide specimens, whether it be blood or tumor specimens. In some cases, saliva, urine, multiple different types of specimens can be collected. And when a patient consents to donate those specimens for research purposes, we agree to all of the information is de-identified, so we can never track the specimens back to individuals, but they're very valuable in terms of the research that we do, especially in sarcoma, because as we've all talked about the fact that there are many different types of sarcomas, but there's actually in many of these sarcomas, many subtypes within the types. So for instance, in GIST that we study, we now know that there are 3 major molecular subtypes: KIT mutants, PDGFR mutants, and kind of a wild type subtype. And so there's lots of differences within patients in terms of tumors. And so the more samples that we can look at, the better understanding we have of the biology of these tumors. And also the more samples that we can study in the laboratory, the more likelihood of identifying targets that we can investigate, new targets, and maybe come up with new drugs that can target those tumors. And so really donating tissue and specimens is important for research, for translational research.
And I would just highlight, and it's a very, very streamlined process at Fox Chase, but wherever anyone is being treated, if this is an option, it's an easy way that a patient can feel good about helping for all of us to understand cancer better and also move the field forward and make progress. And so we only take additional tissue that we don't need for diagnosis. That's not going to change our treatment planning. And frequently in sarcomas, unfortunately, we have large tumors that we can utilize in the lab or freeze to use in the future. And so it's a very way that patients can get involved in and feel good about in terms of research. So we are very, very thankful for our biosample suppository and infrastructure and all the patients who have donated to help us further understand cancer. The next question. So Dr. Van Meeren, do we have any clinical trials available for leiomyosarcoma, either at Fox Chase or kind of nationally, the landscape of clinical trials for leiomyosarcomas?
Currently, the studies that we would have at Fox Chase for leiomyosarcoma would be for a patient who had a particular molecular alteration for which we had a study that would be looking for it. I haven't, there are some studies that are being done at other centers that are looking specifically at leiomyosarcoma. They change, and so I haven't looked recently at clinicaltrials.gov, but that is a great resource for looking for studies. I know that there are some studies at Memorial Sloan Kettering, in part because my former junior colleague is now there and running some of those studies. we certainly have some studies in terms of the radiation studies that Dr. Howell was discussing earlier, which are applicable and patients with leiomyosarcoma can participate in. And again, in phase 1 studies, many patients can participate. So our one longstanding study for leiomyosarcoma and liposarcoma, it now has met all the number of patients' needs for leiomyosarcoma. So we are trying to proceed to get a new study moving forward.
Great, Dr. Greco, there's a question. So would you ever recommend just surveillance on a well-differentiated retroperitoneal liposarcoma instead of just jumping right into surgery? Do you always have to just go right to the operating room?
Thanks for the question. So sometimes patients in that location may have tumors that by biopsy could possibly be, equivocal. So there's a different spectrum ranging from benign things like a lipoma, all the way up to liposarcoma. And sometimes, even though we have a biopsy that may show that this is either what we call an atypical lipoma versus an early or well-differentiated liposarcoma, as you mentioned, oftentimes the only way to kind of confirm that diagnosis is to remove it surgically. So certainly if we had a diagnosis of any liposarcoma, which would kind of confirm a cancer diagnosis, in general, we would recommend that be removed. Part of that depends also on the location of the lesion or tumor as well. But assuming that it can be removed with minimal, side effects or minimal morbidity to the patient, we would generally always recommend that be done, especially if it's already been pre-diagnosed as a sarcoma. That will allow us to confirm the diagnosis, look at other features of the tumor to figure out if any additional treatment is needed.
And I'll just add to that, there are some caveats to that. And I think this is where radiology becomes very important. So liposarcomas are not all the same. So there's well-differentiated liposarcomas. There can be a dedifferentiated liposarcoma. And there can be mixed kind of liposarcomas that we see. And looking at the films and evaluating are critical. In some situations, and either some recurrences and or in primary well-differentiated liposarcomas, we're seeing the patient with one frame in the movie. So sometimes we'll do short interval surveillance and look at growth patterns and decide that there are some patients that if they have a lot of high risks or comorbidities, and we get serial imaging in short intervals that show no change in it, that some patients that we do watch. But in general, if you have a liposarcoma, we generally recommend an intervention, including surgery or sometimes chemotherapy or radiation, but it really depends on what it looks like on imaging and under the microscope as well. Dr. Howell, there's a question about the radiation sheets that we have talked about earlier. Are they ever put in to prevent sarcoma? And have we used them in any patients with leiomyosarcoma or only for if you're currently taking it out? So is it ever used as a preventive measure? And I guess you can also comment on kind of when we put them in or what we think the best indications are.
Yeah, so thanks for the question. So typically we do these to prevent a reoccurrence, but we would only do them if the surgeon was in the body cavity. I wouldn't open a patient up just to put brachytherapy in or these sheets in de novo. So we'd only go in with the surgeon when they're removing a tumor. And typically when we are using these now is we are using them in the setting of a reoccurrence of a sarcoma or a sarcoma where the surgeon just can't get good margins. And typically that occurs when you're next to an organ or next to a vessel. And Dr. Farmer or Dr. Greco are going in and they want to get a huge margin. They want to get a lot of normal tissue in between so they know for sure they have every single cell. But when they can't do that, they remove as much as they can. And along with me in the OR, we determine this area of highest risk for a reoccurrence. And of course, we don't want that for the patient. So then at that time, we would lay down one of these sheets. Now, in decades past, they have tried this brachytherapy or this radiation directly inside the patient, but it was very tricky in the abdomen and pelvis because you'd have to put in these long tubes and these tubes could move. And so the toxicity rates were too high with that. And so we've abandoned that, at least in that area. In specific cases, like for a retreatment of the extremity or other locations, I may still choose to use those interstitial brachytherapy catheters. But typically in the abdomen and pelvis, if we're going to go in and remove a retroperitoneal sarcoma, we would put in these sheets, and they kind of look like those old candies. I don't know if anyone remembers it, but they used to be those little strips which would have the sugar dots on them. And so they look just like that. And those little sugar dots are the radiation. And just like those candy strips on one side had the candy, on the other side didn't, this strip is shielded on one side. So the surgeon and I can lay down that little strip and it can have the radiation pointed to that margin that's at risk, but the other side is coated and it's protected. So when the surgeon puts the bowel or the kidney or the liver on that other side, it's actually shielded. It's a gold plate that will shield that radiation to those normal organs. And so we've successfully done that with many different histologies because, to be honest, the radiation works pretty well for all histologies. Now, some histologies are very radiosensitive, but I've yet to find a sarcoma histology that is radio resistant. So we will put that down more based on the patient's history and based on their anatomy rather than a specific histology for the brachytherapy.
And I would just, those sheets, it's not, it takes planning. So when we do implant them, it's not an off the shelf product that we just say. So we have to really work as a team beforehand and really closely review the imaging. And if there are really close areas that we're concerned about, where I know that we can resect the aorta, but don't particularly like to do that. That's the biggest artery in the body. If it was really close to that area and we know that there's a section, then we can put these sheets down or in other places. Along those lines, Krisha, so what about if someone's had radiation and then recur, can you re-irradiate or is it a one-time deal?
Yeah, so it used to be that way. And I like this phrase. Someone once said there's oncolores out there. And I think this is an oncolore. It used to be that you couldn't re-irradiate. And probably 15 years ago, you would hear that all the time, or very few centers, they would do that. Nowadays, it's very common practice, especially at tertiary cancer centers or tertiary care centers, to re-irradiate. But you have to know what you're walking into and plan the best approach. So these things that we're talking about, the brachytherapy, are one way to approach this. Another way to approach this is there is a developed technology here at Fox Chase called pulse low dose rate radiation. And so it's a very slow delivery of external beam radiation. And we had some protocols open in years past, and it proved the capability of this type of radiation to deliver radiation with minimizing toxicity for these patients who have had radiation before. So that's another option open to us.
Great. Anjali, in terms of when patients are coming in for either initial evaluations or follow-ups, what do you think they should be kind of thinking about, or what questions should they have for the provider from your standpoint? And also kind of how should they get their family involved in kind of their treatment planning?
So thank you for the question. I think there's oftentimes a lot going through people's minds when they're coming, deciding where to be treated, what kind of questions to prepare for. One of the things we often think about is, how is this going to impact my life? So when you think about not just the diagnosis, but the treatment that's being offered to you, we always recommend that you give a lot of thought to how is this going to impact your life and what is going to be the process? Like, how involved is it? Are you going to be able to work during treatment? Are you going to be able to take care of your family, your children, whatever's important to you? I think it's important for you to convey that to the providers so that they have an understanding of, who you are and what you're looking for and how best we can support you and customize treatment options that would benefit you the most.
Thank you.
Mhm.
We have a couple more minutes. Oh, there's a little echo. Meg, are there any recent advances in the treatment of Ewing sarcoma, particularly for a case that's proven resistant to the standard chemotherapy regimens in an adult?
So I think that some of the things that are being evaluated right now are really focusing on a novel way of thinking about Ewing sarcoma. And this is also true of synovial cell sarcoma. These tumors are driven by genetic changes that occur because one piece of a gene or of a chromosome on one chromosome flips over and connects to another, and they create a new protein. And these translocated fusion proteins have specific characteristics and seem to be really involved in or interact with a process called epigenetics. And epigenetics is complicated, but it's really how genes are regulated in terms of what is being turned on and activated versus those that are not. And we're really fortunate at Fox Chase, and actually today officially we Dr. Fisher, the head of the center, announced our Epigenetics Institute. But there are some new therapies that are really trying to target the proteins that are involved with this control. And in Ewing sarcoma, it's also been studied in synovial cell sarcoma and some other of these tumors that have translocations. There are starting to be some inhibitors that are targeting that. Epizyme, who is one of the sponsors, makes a drug called dezemistat, and that is an epigenetic inhibitor and works in epithelioid sarcomas and also in some malignancies, hematologic malignancies. But in Ewing sarcoma, there are some drugs that are really trying to focus on that. And we will be joining a study in the next, I would say 1 to 2 months that will be looking at that kind of an approach, including some patients with Ewing sarcoma. It will be in combination with chemotherapy. So depending on what somebody's had, they may or may not be able to participate. So that's sort of the newest thing that I'm aware of in Ewing sarcoma.
Thank you. One question I'll take quickly is, there was a question if there's a difference in the retroperitoneum of the term atypical lipomatous tumor versus a well-differentiated liposarcoma, which we literally were just kind of discussing for the extremity 2 hours ago in our tumor board. But there, in the retroperitoneum, they're the same term. Frequently, there'll be interchange where an ALT or atypical lipomatous tumor, which more commonly we'll use on the extremity, would also be called, and in the retroperitoneum, we tend to call it more so a well-differentiated liposarcoma. So it's frequently a similar definition. I have 2 more questions. I guess one, Dr. Greco, with COVID and the COVID vaccines. And I would just mention that we are currently giving the vaccine to Philadelphia residents if you have not been vaccinated, and our patient at Fox Chase for now. We're hoping to expand that shortly to other counties. But Dr. Greco, are there any concerns after either post-op with follow-up scans like CAT scans or MRIs, are concerns for interactions that can cause any aggravation or anything in terms of the COVID vaccine and either recurrence or imaging and such?
So that's a good question. I think in general, we encourage and want all our patients to get the vaccine, as soon as they can. It should not affect anyone's ability to have surgery, for example. We want patients to get it, as quickly as they can. And certainly, if it were something post-surgery, we wouldn't necessarily recommend or say that you could not get it. We would encourage you to get the vaccine. Now, in terms of, surveillance, getting the vaccine does, initiate an immune response in most people, especially, depending on what vaccine you get, the second dose for some of these vaccines. And we have noticed that patients can get enlarged lymph nodes after getting, especially that second dose of the vaccine. Those may show up on imaging. And so one thing that is important is to let your provider know if and when you do get the vaccine so that we can be aware of that. But it would not affect you getting your surveillance imaging, getting the treatment that you need for your sarcoma, but it is important information that we should know about to take into consideration, especially when reviewing any imaging.
Great. And we'll do one more question quickly, although it's not a quick answer, but and I think Dr. Rink and Dr. Van Meeren can kind of highlight, I think, both novel therapies, but are there any new GIST therapies or is Gleevec or imatinib still the gold standard? So Meg, maybe you can talk from a clinical perspective, and then maybe Dr. Rink, you could talk about maybe from a preclinical perspective.
So for most patients, Gleevec is still the gold standard for the first line therapy. There are now, I guess, 4 additional drugs that have been approved: Sutent, regorafenib, ripretinib, and avapritinib. Avapritinib is really approved for a subset of patients who have platelet-derived growth factor exon 18 mutations. So a very specific subgroup of patients. We continue to look and participate in clinical trials and work with Lori on thinking about new ways of targeting GIST.
Yep, we just actually published a study that used kind of a profiling of GIST tumor samples to look at the Kinome, which is measuring all of the active kinases. These are proteins found in tumors that kind of regulate and orchestrate cellular function inside of the tumor. And they also happen to be highly druggable types of proteins. So those drugs Meg just mentioned, Gleevec, sunitinib, regorafenib, these are all kinase inhibitors. And so the thought process was, if we could look at a large number or a high fraction of the kinases within GIST and different subtypes of GIST, could we find new targets to go after? And we identified one that was just published, which is a cell cycle inhibitor. The cell cycle is involved in cell growth for the cell. So this is kind of a preclinical study that we're trying to investigate a little bit further. And the hope is that Meg will be able to initiate a clinical trial based on that preclinical data.
Great, thank you. This was a great discussion tonight. For anyone out there, if you have other questions, you can post them to the live chat, and we will work to answer them in the next, this evening or the next few days, and get to any other questions or answers. That's our time for the evening, and we appreciate you spending your time with us. Thank you again to all of our exhibitors and the advocacy organizations for participating and our continued relationship. Thank you to our survivors who sent in pictures and words of encouragement. And I want to thank all of my amazing colleagues for joining this evening: Dr. Greco, Hal, Anjali Albanese, Dr. Van Meeren, and Dr. Rink. Thank you. It's a pleasure working with all of you. There are 3 other Together Facing events taking place virtually this spring at Fox Chase: blood cancers, head and neck cancers, and prostate cancer. So please, if you have friends or family that are interested in these events, share them on social media and join. You can check them out on the Facebook webpage or on the Fox Chase site. And we hope to see you in person soon, as if you can get vaccinated, we recommend getting vaccinated. Good night, and thank you, and take care.